So it is now my pleasure to introduce Dr. Eunhee E from Mayo Clinic in Rochester. She's a professor of pathology at the Mayo Clinic College of Medicine and a thoracic pathologist who has worked, I think you joined the Mayo Clinic over there in Rochester in 2006. Dr. E originally came from South Korea after graduating from the Seoul National University College of Medicine and completed the AP residency there, and then she repeated the APCP residency here in the United States in California. And then she worked at UC San Diego for 14 years before relocating to Mayo Clinic. Her expertise is in both non-neoplastic lung and also in oncologic lung, neoplastic lung. Her talk today is actually about two cases, two mesothelial lesions. One of them I also was personally involved with. So please welcome Dr. E. Thank you.
Good afternoon, and it's a great honor to be here. And today I will talk about two mesothelial. It's not a mesothelioma case; it's a mesothelial lesions, and it was initially misdiagnosed mainly due to the prior biopsy was diagnosed with a different diagnosis. So it's mainly due to like a self-imposed error. It's nothing to do with anything else. And for mesotheliomas, you may know that most of them may go to litigation. So it's not about any error. So you have to be really well versed about mesothelioma when you make the diagnosis, because potentially you may get the position from each side, actually, either employers or employee side as workers come. First case was 58-year-old man who presented with right pleural effusion chylothorax and underwent the pleural peel for mechanical and chemical pleurodesis. And I get to review this case because a patient came into Mayo Clinic about 9 months after the procedure. So as you can see here, it's pretty like zonated, very even, nothing really going every which way. And it was diagnosed as pretty much reactive. Some atypia, but basically reactive benign process. And I didn't think too much, and it was diagnosed by a very reputable pathologist. So, well, I just quickly looked at, and I kind of paraphrased the diagnosis, and I gave the similar diagnosis and forgot about it. But the next day, I got a phone call from an intern who was asking, can it be lymphoma? Because there was a biopsy done at Mayo Clinic more recently, and that was diagnosed as atypical lymphatic cell proliferation or something. So I looked it up quickly, and I didn't do my due diligence. So I didn't even know the patient had a biopsy. And indeed, it was diagnosed as atypical lymphatic cell proliferation. And there was another biopsy from a buttock more recently, and the result was still pending. When I looked it up, well, it's kind of a subtle, but still quite a bit of abnormal cell proliferation that had a lymphatic phenotype. So that was a pretty good diagnosis. Not enough for malignancy, but atypical. However, the buttock mass, it is too much. It is enough to make the diagnosis of malignancy, at least in growth pattern and cytologic atypia. And the cells do have the same phenotype, CD31 positive, FLI1 positive, and D240 positive. So the diagnosis was high-grade angiosarcoma lymphatic phenotype for that buttock mass. So of course, I had to re-review the pleural specimen from about 9 months prior. So this one had essentially identical morphology, very, very atypical. And now by all means, it looks like angiosarcoma. If I didn't have the bias of the prior diagnosis, I might have wondered about angiosarcoma, but I didn't. And the CD31 and D240 were also positive, while A1, A3 was completely negative. So, of course, it's not mesothelial proliferation. So, diagnosis was revised as metastatic high-grade angiosarcoma, lymphatic phenotype. The patient received chemotherapy, but didn't do very well, didn't take the therapy very well. And I was told that he is on supportive care for the most part. For this patient, though, probably the little delayed diagnosis didn't do too much of impact because of this grave prognosis of high-grade angiosarcoma. The second case was a 67-year-old man who was incidentally found to have an abdominal mass near the liver and duodenum. So he had a needle biopsy first and then a resection afterwards. This is a needle biopsy. So if you don't think too hard, well, it looks like an adenocarcinoma. It's very atypical. It's a malignancy for sure and kind of a glandular appearance. And it was reviewed by a GI pathologist who did a CK7 and 20. 7 is diffusely positive, but 20 is negative. For whatever reason, he did a GERA3 that is diffusely positive. And other the immunostains CDX2, SET-B2, P40, TTF1, hemoglobin, probably because of GERA3, and GCFP15 and PAX8 were all negative. So basically, it was diagnosed as poorly differentiated adenocarcinoma. Because of the location, it was suggested as a pancreatobiliary or upper GI origin. And then I received excision specimen while I was on duty for frozen section. So I knew that the GI pathology diagnosis adenocarcinoma. So I start with adenocarcinoma. What is the primary of this tumor? So I consulted our GI pathologist mainly for where the primary, and he recommended many stains, but it really didn't pan out as to the primary site. So basically, I signed out as adenocarcinoma non-primary. And oncology sent it out to Tempus for just finding, to find where the primary was. And to my surprise, the diagnosis is a 99% probability of mesothelioma. So, oh well, that's pretty confident. They must have good way of telling it. So, well, I backpedaled and I did a stains. All 4 stains that I used for mesothelioma, epithelioid meso at least, calretinin, WT1, HEG1, and D240 all were positive, whereas the claudin 4, very good, very specific epithelial marker was dead negative. BEP1 and MTEP were negative, but it doesn't matter because it's not entirely sensitive. It doesn't rule out mesothelioma. It was also negative for ALK and had a somewhat low Ki67 index, but it is malignant tumor. So it was revised as epithelioid mesothelioma adenomatoid type. So it was a little painful lesson. If I didn't kind of think as a adenocarcinoma, at least I should have or I would have thought about adenomatoid mesothelioma, but I didn't. So I learned that we always need to look at every case with unbiased, fresh eyes with observation and the clinical and radiologic findings, and also do due diligence about previous or concurrent biopsies. So I have to blame myself and no one else because I didn't do the right job. Again, you will always be challenged whenever you make the diagnosis of mesothelioma, so I'll just update you with a recent knowledge. I'll begin with a few basics and changes in 2001 WHO Blue Book. And I'll show you how to approach to differential diagnosis between benign versus malignant, and when it's malignant meso versus other types of malignancies. And review old and newer immunochemical and genetic markers used for differential diagnosis. And the concept of mesothelioma in situ is much better refined now. And I will summarize the current literature. And the grading of epithelioid mesothelioma is required, even for small biopsies. So I will go over and also show some issues. There are some distinct epidemiologic and molecular differences depending on the sites. Of course, the pleura is the most common sites. Up to 90% of mesotheliomas are pleural, male dominant 3-to-1, and mostly elderly patients, whereas the peritoneal is much less common, and the male to female ratio is 1-to-1. And it can occur in very young patients, like 20s and 30s, especially with ALK rearrangement or EWS1 fusion with the various fusion partners. And mostly diffused, and rarely it can be localized. And in 2021, main thing was they got rid of malignant part. So you just call it mesothelioma in nomenclature. It is mainly because even if we say benign mesothelioma, like cystic, whatever is benign, they still stuck with the mesothelioma idea, and the patient may get horrendous over-treatment. So mesothelioma cannot be used in any other than genuine mesothelioma. So well-differentiated papillary mesothelial meso now is mesothelial tumor. Cystic and multicystic benign meso now is a lesion, and even is recommended to use peritoneal inclusion cyst. Avoid all this wording. And you cannot use that in the pleura, so maybe you can use the pleural inclusion cyst for the pleural counterpart. In major classification, there are 3 subtypes in mesotheliomas: epithelioid, sarcomatoid, and biphasic. And benign side is very rare in the pleura to see adenomatoid tumor, but you can see it. It's also less common, but well-differentiated papillary mesothelial tumor is recognized as important benign lesion. And now mesothelioma in situ is officially acknowledged as a category. In epithelioid mesothelioma, there are various architecture and stromal patterns and cytologic features. Solid and micropapillae are associated worse outcome, and the rhabdoid and pleomorphic cytologic features are regarded as unfavorable features. And you see this tubular papillary. This one is more favorable, but the micropapillary without fibrovascular core or solid, especially 50% or more, it will be associated with unfavorable. And this is a incidentally found adenomatoid tumor you may see in the pelvic biopsy. And this is in the myometrium. And the architecture is very similar, and this is actually the case I just showed you. So this is adenomatoid type of mesothelioma, so don't forget to consider that when you have some glands in there. Sarcomatoid is much worse in general than epithelioid mesothelioma, but even worse if it is a transitional or pleomorphic. And desmoplastic meso is regarded as unfavorable subtype. Generic spindle sarcomatoid meso has more slender cells than transitional one, plumper, literally between epithelioid and this slender spindle cells. This is worse. And desmoplastic meso, I always say to our trainees, it looks spooky. It's very hypocellular, but it's like impending doom or something. Something is coming. And the storiform or pattern is at least in 50% of tumor that's regarded as desmoplastic tumor. In high power, though, it can be deceptive. So that's why it's very hard to make the diagnosis of desmoplastic meso, because on high power, very little atypia. But when you don't have a capillaries in there, that's a little tip-off. And when there is a necrosis, it's a bland necrosis, no neutrophils, nothing. It's a very, very clean necrosis. That's another tip-off for desmoplastic meso. Biphasic meso has the epithelioid and sarcomatoid components. And the resective, the specimen, you require at least 10% of each element, but in small specimens, any percent will go as a biphasic meso. In either specimen, you have to give the percent of sarcomatoid component. Many times, mesothelioma patient may not have a resection, so that's why the small biopsy may be the only specimen you will get. That's why we try to get as much information in the small biopsy. So biphasic epithelioid and sarcomatoid, maybe 50 and 50. And this one has a lot more sarcomatoid, maybe 90 plus, and then epithelioid. So main differential situation when you deal with a mesothelial related pleural or peritoneal biopsy will be reactive versus malignancy of any kind, meso and other types, and epithelioid meso versus carcinoma or any other epithelioid malignancies, sarcomatoid meso versus sarcomatoid carcinoma or other sarcomatoid malignancies, and the biphasic meso versus any biphasic malignancies. In reactive mesothelial proliferation, you may see quasi-malignant features. Paradoxically, you may even see more cytologic atypia and brisk mitotic activity than mesothelioma. So that's why the first case, the very high cytologic atypia, I just put, well, reactive can have a lot of atypia, but you have to be careful. And when you have a necrosis, you tend to have many neutrophils. And the papillary excrescence and the pseudo-invasion due to entrapped cells and the pseudo-invasion due to pseudo-fat can be told from the real mesothelioma. And zonation is a very helpful thing. And this is a very nice diagram by a review article by Andy Chirk. And whenever it's a horizontal within the thickened pleura, that's pretty much benign. And if it is at the surface, it could be potentially a malignant, but it is more likely benign. But if horizontal lesion is within the fat, that's likely malignant. And anything goes vertical like this is more likely malignant. So you see here, that's a post-viral pericarditis. And again, keratin stain is very helpful to tell the growth pattern. So this is again benign, this is another benign, whereas this epithelioid meso go vertically and make even tumefactive growth and invade the fat vertically, that's the meso. So when you have an ancillary test for meso versus reactive, you basically to establish malignancy, not for finding the cell phenotype. So don't try to do meso versus other types of cells. It's basically, it's a mesothelial cells, but it's benign or malignant. That's usually the question. Keratin can be really helpful. I can get by with many, mostly benign thing, but I want to make sure it's not meso. Then I just do A1A3 to make sure no infiltrative or tumefactive growth. And then many molecular or IHC testing can be done. The first one was CDKN2A FISH, homozygous deletion. As you can imagine, homozygous deletion is not easy. You have a very good tech who can detect it. So BAP1 and MTAP is by IHC. That's the loss of this protein expression is much easier. And it's not 100% sensitive. So the retained protein for both does not rule out mesothelioma. And both of them give a good sensitivity and 100% specificity. If there is, that's malignant. And the Merlin encoded by NF2 gene is in the horizon, but there is work in progress. It's not for prime time yet. And EWS alphas or CRAP fusion can be seen in young patients for peritoneal meso that is detected by FISH or NGS, whereas ALK rearrangement can be detected by IHC as well as FISH. So don't forget to do those testing when you have a young patient in peritoneal mesothelioma. In the epithelioid meso versus carcinoma, these are the 4 markers that I use. And I'll talk about HEG1 a little bit because it's a newest marker. And some people include CK56, but personally, I don't like it because it's so much overlap with the other carcinomas. So these my 4 markers used, and there are many other obsolete markers used decades ago and no longer in use. And the epithelial markers, so again, in epithelioid meso versus carcinoma, you have to establish which cell type, not the malignancy. So usually you don't need to do MTAP or BAP1, rather you have to define which cell type. So Claudin-4 is the most specific one, although it's not 100% sensitive. And all these markers have overlapping, and the site-specific epithelial markers can be helpful. If it is positive, that's pretty specific. Again, Claudin-4 is 100% specific. None of the epithelioid meso is positive, whereas it's not 100% sensitive, however. And this tumor really mimic meso in that it grows along the pleura and grow along the interlobular septa and the pleural-based mass, but it was pleural epithelioid hemangioendothelioma. So think about it, it won't hurt to consider it. Not all epithelioid tumors are carcinoma or meso, and the CD31 can help. And even if you look at closely, you can see the morphology of EHE. And it needs to be differentiated from epithelioid angiosarcoma because prognosis is very different. So CAMTA is the stain that you want to do to confirm it is a EHE. Differential between sarcomatoid meso versus sarcomatoid carcinoma or other malignancy is arguably most difficult because basically it doesn't stain with anything. The meso doesn't mark with the meso marker, and carcinoma doesn't mark with the carcinoma marker. So if it is a keratin positive, I often call keratin positive sarcomatoid malignant neoplasm and put the ball back to the clinician's court, and you decide with the clinical and the radiologic features. And it's miserably overlapping between each other. But be aware, TTF1 can be helpful. Believe it or not, sarcomoid carcinoma of the lung, about 50%, we did a study with a sensitive marker, up to 50% may be focally positive. That can be a good tip-off of a carcinoma. It at least favors carcinoma. And the GATA3 is now used widely to tell sarcomatoid meso versus sarcomatoid carcinoma in 2 senses. If it's diffusely positive, it favors meso. If it is dead negative, it favors carcinoma. If it is in between, focally positive, it's not informative. So GATA3 is kind of a last resort, but it may or may not help you. Biphasic meso versus other biphasic malignancies. These are the practically 2 situations, non-small cell carcinoma with sarcomatoid component and the biphasic synovial sarcoma. Other things are in the differential, but it's technically in, but usually not a practical problem. And the biphasic meso, you have an epithelioid and sarcomatoid element. Kerretinin tends to stain more epithelioid elements and less so in the sarcomatoid components, whereas WT1 and the D240 tend to stain both elements. So be aware, kerretinin is not very sensitive in the sarcomatoid element. And the Claudin-4 is, should be negative. Biphasic synovial sarcoma, we can get by with these 2 stains. We no longer do FISH or molecular study because it does such a good job. And this is more specific marker, and this is more sensitive marker for synovial sarcoma, and no longer do TLE1 or BCL2 because these 2 does pretty much good job for synovial sarcoma these days. A few words on HEG1. This was first described in 2020. And it seems pretty good. In that study, 95% of epithelial meso was positive, and none of the pulmonary squamous cell adeno or large cell carcinoma was positive. Very specific. But be aware, do not use in the peritoneal meso because high-grade serous carcinoma, significant minority up to almost 20% is positive. So be aware that the HEG1 stains high-grade serous carcinoma, and sarcomatoid meso is much less sensitivity, but still very good specificity. So it has comparable sensitivity to calretitin WT1, D240, and CK56, but better specificity. That's what is claimed. And it is a cytoplasmic and the membranous positivity. So you can see here. And Andy Church and Julia Nasso, who was our fellow last year, published a study that HEG1 and Claudin-4 is a two-marker thing for meso versus carcinoma, like you do like TTF1 and P40 for adeno versus squamous. So it may be useful for limited specimen. I have tried for a few times, and it seemed to be working. So you may consider that if you have a small biopsy. BEP1 is acts as a tumor suppressor, but it is involved in all kinds of cell cycle, including DNA repair and damage signaling. And the one word is that BEP mutation relate to female predominance, epithelioid histology, and favorable outcome. And it's a loss of nuclear positivity. So it's much easier to evaluate than MTAP that I'll show you shortly. So you always have to be internal positive control. There is a BEP1 tumor predisposition syndrome due to germline mutation, and it's autosomal dominant inheritance, and it can be important high risk for many other tumors than meso, including clear cell renal cell and melanomas at very young age, like 20s and 30s. MTAP also may function as a tumor suppressor. This gene, MTAP gene encoding the MTAP protein, is next to CDKN2A. So when it is deleted, they go together. So you can imagine MTAP IHC to detect MTAP expression can be a reliable surrogate. It's a pretty good, like over 95%. It's not 100%, but a reasonably good surrogate for CDKN2A gene deletion. So we seldom do this fish testing anymore. Combination gives the good sensitivity and always 100% specificity. As I said, this is cytoplasmic stain. When it is positive, usually it's nuclear and cytoplasmic. When you evaluate loss of it, cytoplasmic loss is what you look for. And this is a good example of it. It's the loss of nuclear. So it's pretty clear. But I often struggle to evaluate MTAP expression because usually messy, very messy. So a recent study from MSK showed this particular clone, 1813, did much better job than another clone they compared. Actually, I read the paper and it's very impressive. So you may want to try this one if you have trouble with a current clone. And the Mayo may transition to this clone. Again, NF2 gene that encodes Merlin. So the Merlin IHC is a still work in progress because there are many problems, such as intratumoral heterogeneity, and it depends on platform and clones, and then even more so is a genetic alteration. IHC results do not always correlate, so that's a bit of a problem. So we do not use it yet. It may become one day. Other markers are in the horizon, but we are not using it, and I was able to get by. You know, you may do P53, but I don't usually use it. And one review article published earlier this year by Harvard group kind of said, you know, a review article, so it's not their study, but they said Now NGS may suggest the type of the tumor. In fact, if you remember our second case, the Tempus NGS proposed the type that I mislabeled. So it may be coming one day by a combination of all those generic profile. I don't know how good it will be, but it may be coming one day. And the emerging technique includes a DNA methylation-based classifier, like in the CNS tumor or renal cell carcinoma, for example. And the deep learning-based classifier of sarcomatoid mesothelioma has been published by Julia as well. Now, mesothelioma in situ has been talked about more than 30 years, but it didn't take any steam until very lately. Now, it is officially acknowledged as a group, as a category, important one, and a lot of criteria, actually these are all the criteria written in the WHO book. So it has to be two things. It shouldn't have any tumor mass, and obviously in situ, so it should not have any invasion if we are pure in situ tumors, although in situ tumor may have invasion elsewhere in the same patient. And usually non-resolving pleural effusion, you require to have a molecular proof for now, either BAP1, MTAP, or CDKN2A homozygous deletion. So you require to have those. Prognosis is probably mainly depend on the risk of progression to the invasive mesothelioma. So in situ by itself is not gonna kill the patient, but if it develops meso, then it will. And a few other points are, it seems that pleural and the peritoneal MIS seem to have a different genetic backgrounds as well as some behavioral difference. So Sanya Dasik published a paper. When you look at the details of BAP1 somatic abnormalities by whole exome sequencing, they had a different expression, although they may have a same BAP1 loss in pleural and peritoneal MIS. And it is well known that MTAP loss is associated with worse survival in MIS because they tend to develop invasive mesothelioma more quickly. And if you have any repeat pleural effusion or ascites for no clear etiology, it won't hurt to run BAP1 and MTAP to rule out MIS. And again, some biologic difference between pleural MIS and peritoneal MIS in that 59 months for pleural as opposed to 12 months for peritoneal MIS to develop invasion or median survival. So for whatever reason, peritoneal MIS seems to do worse than peritoneal MIS. And this is one case, patient presented with recurrent ascites, and you have this cell proliferation here. And as I said, I usually start with a keratin stain. It highlights all this proliferation, but there's no invasion or mass to speak of. But it is not reactive because MTAP was lost. If you see here, if you squint your eyes, there is MTAP loss in those proliferating cells. So it was diagnosed as MIS in the peritoneum. One other thing that I want to point out is MIS can mimic well-differentiated papillary mesothelial tumor. In fact, I published a study in 2018 of 8 well-differentiated papillary mesothelial tumor. Back then, it was mesothelioma. And 3 of them showed BAP1 loss. And 2 of them had synchronous peritoneal mesothelioma elsewhere. And the remaining 1 patient developed invasive meso 10 years later. So now it is probably, in retrospect, that these 3 cases represent MIS mimicking well-differentiated papillary mesothelial tumor. Larger series by Mesopath study published in 2023 had 8 cases of a pleural and the peritoneal MIS. And all of their cases are BAP1 loss. No one had MTAP loss. And 3 of the pleural patients had microscopic fossa invasive meso without developing overt mesothelioma for a long time, 94 months, up to 94 months. And the 5 peritoneal cases had microscopic or single nodules of invasive meso, but alive with disease, but much shorter than the peritoneal, the pleural MIS. So this is from our study. So this is well-differentiated papillary meso with intact BAP1 expression, but one of the cases that, developed the meso 10 years later already had a BAP1 loss before developing overt invasive mesothelioma 10 years later. Of course, BAP1 loss was found at that time as well. Many studies showed slow progression. Our case was 10 years and 2 to 13 years. So arguably Andy Church is one of the guru in the North America, and he pointed out that we may not have enough follow-up to consider well-differentiated papillary mesothelial tumor as completely benign tumor, because most of series may not have enough follow-up. So it won't hurt to do the BAP1 and MTAP stain. So that's what we usually do at Mayo Clinic these days. Now, finally, grading of epithelial meso. Now, again, both the biopsy and resected specimen requires grading because that correlates with the survival. And the tumor grading is based on nuclear grading and presence or absence of necrosis. Nuclear grading has 3 variables. Nuclear, 2 variables, nuclear ATPS score 1, 2, and 3, mild, moderate, severe, mitotic count 1, 2 to 4, and over 5 mitosis. So 1, 2, and 3. And the score 2, if you add up the mitosis and ATPS score as a 2 and 3, that's nuclear grade 1, 4 and 5 is 2, and 6 is 3. And necrosis present or absent. So if a nuclear grade 1 with or without necrosis, or nuclear grade 2 without necrosis is low grade, whereas you have a nuclear grade 2 with necrosis will be high grade, as well as the high nuclear grade. So score 1 of a nuclear atypia, score 2, and score 3. And so this is one example I want to grade with you. And you have a score 1 of a nuclear atypia, and there was no mitosis. So score of 2 because of 1 plus 1. So nuclear grade 1 with no necrosis. So it's a low tumor grade. And this one is higher nuclear grade in that it's almost like a rhabdoid features that is associated with unfavorable outcome. There were occasional mitosis, and there is necrosis on the right hand. So nuclear ATPS score of 3, mitosis count was 4 per 2 square millimeters. So score of 2, 3 plus 2 is 5. So nuclear grade 2 with necrosis, so high nuclear grade. That's how you grade. So this grading has some issues though. Reproducibility may be a bit of a problem, and although relatively simple and easy, still labor intensive. And some experts advocate, how about include other the factors that are associated outcome, like solid and micropapillary or rhabdoid pleomorphic nuclei, for example. And how about genetic alteration? I said BAP1 loss is favorable and MTAP loss is unfavorable. So shouldn't that be accounted for into in the grading? And you cannot count the mitosis in the cytology specimen because you cannot make 2 square millimeter denominator. And now it is a prognostic thing, purely prognostic, but can it be predictive marker? For example, you don't do extrapleural pneumonectomy for sarcomatoid meso, but all epithelial mesothelioma can be a candidate potentially. But how about high grade may not be. That kind of a prognostic, predictive value was discussed these days. So with all those controversies in mind, we did a very simple-minded study, something like a Ki-67 index in lieu of histologic tumor grading. This is model for Ki-67 index in neuroendocrine tumor of the GI tract or pancreas, right? So we got 96 pleural mesothelioma cases at Mayo with all clinical data. 2 pathologists assessed the tumor grading by reviewing these parameters. And in parallel, we did a Ki-67 proliferation index by DIA and correlated with overall survival, and also look at the correlation with a tumor grade by mitotic score in comparison with Ki-67 index. That's the main thing we looked at. 2 reviewers did pretty good job in correlating mitotic count. So the pretty similar mitotic counting. So that was good. The average mitotic count and the Ki-67 correlated really well as well. So that was a good thing. And a tumor grade was better correlated to mitotic count by looking at the p-values by these numbers somewhere here. But Ki-67 was not that bad. So it's a slightly worse, but still comparable. And one other things we found interesting was this is a hazard ratio. So when we look at the mitotic count, nothing happened until mitotic count of about 5. And then it hiked up to 10, and then even gone really high. So when we look at the survival, the 10 made a very, very big difference. And currently between 5 to 10 and 10 or over in the same score of 3. But they did look a little different. Whereas that 1 and 2 is here, but they look the same. So that was one thing. And the 30% of Ki-67 index was pretty good. So if my conclusion of this study was Ki-67 proliferation index by DIA associated with a tumor grade as well as mitotic count, its predictability of overall survival was very comparable with mitotic score. So it could be a potential surrogate for tumor grade. As I said, the current category is a little problematic because 0 to 4 or 5 doesn't do anything, and then 5 to 10 and 10 or more is different. So maybe this is better category if we use this scoring, 0 to 4, 5 to 9, and 10 or more, because that's where we found the hazard ratio really changed. So few take-home points. Don't do shotgun approach with just 100 immunostains. Just find what your differential diagnosis and cater the immunostain to your differential. BEP1 and MTEP, maybe marlin or fish for these CDKN2A are important for reactive versus meso, but not necessarily meso versus other types of malignancy. It's helpful, but not necessarily it's meso because it's lost. And be aware of some antibody clones do differ in performance. And consider BEP1 and MTEP IHC for any flat or papillary mesothelial proliferation with unexplained pleural effusion and ascites and well-differentiated papillary mesothelial tumor. And molecular and deep learning approaches may be on the horizon, and the grading of epithelioid mesothelioma may need a revision. That's it.
Thank you very much, Dr. E. We don't have a lot of time for any question. Do you have maybe one question? Okay, got it.
When you're comparing the mitotic count in Ki-67, were the mitotic counts all done on glass slides, or was digital slides?
Yes, glass slides. Okay. And in fact, we are doing another study comparing with the digital slide right now.
One quick thing regarding adenomatoid mesothelioma. In many other textbooks or older papers, you may find the term microcystic. They are actually interchangeable because microcystic was the preferred term of Dr. Corson. I trained with him in thoracic pathology. He retired when he was 90.